Assalamu alaikum. Hello, everyone. Welcome to BYOS Academia. I am Dr. Mahziba Rahman Chowdhury, and today I'll be talking about a very important topic, that is Pentacam Evaluation. So let's get to know this Pentacam. Pentacam is a combined device that consists of slit illumination system along with a shine flood camera. What does it do? It captures multiple images of the anterior segment of the eye and generates a 3D model of the cornea and other structures. So this is known as the comprehensive anterior segment analyzer. It gives us, what does it give us? It gives us a shine flood image of the anterior segment, a three-dimensional anterior chamber analyzer. It gives us pachymetry. It is also a cataract analyzer. And most important, we get to know the corneal topography from here. Now, before we go for interpretation, we need to know how to understand the maps. Before that, the color coding. We need to have an idea about the color coding. We can see an array of rainbow colors over here. So the red and the orange, these are the warm colors, and they represent high powers or the steep curvatures or high diopteric values. That is K4850 will have these red colors. Now the cool colors, that is the blue and the violets, they represent the low powers, that is the flat corneal curvature or low diopteric power. And lastly, the greens and the yellows, they represent the value of the normal cornea, such as they can be around 41, 42 diopteric power. And let's have a look at the colors in the corneal map. Over here, we can see that the center is red. So this means that the central part, this is a bow tie pattern of a shark. So the central part, it has a red color. That is, this is showing that it has a high corneal curvature or high diopteric value. Now we will have a look at the 4-map refractive display. So these 4 maps are the ones that are normally present when we see a printout of the Pentacam. Over here, what do we get to see? We get to see the anterior sagittal map, or which is known as the axial map. Then comes the anterior elevation map. Then comes the posterior elevation map. Lastly, the pachymetry or the corneal thickness map. So these 4, I'll be talking about these 4 because these are the ones that we commonly see. So the axial map. The axial map, what does it do? It gives us an overview view of the corneal curvature. It has a downside, that is the minor variations can be missed in this axial or sagittal map. And in this map, we can see very different demonstrations. So like what we see here is a round pattern, oval pattern. Then what is coming here is a superior stiffening, followed we can see an inferior stiffening. What is this? This is the bow tie that is we wear with the shirt. So this is the bow tie pattern, but this is regular. That is the superior and inferior bow tie are both similar in appearance. This is also a bow tie pattern, but what happens here? This is having a skewed angle. That is, the angle is skewed. One of the angle is skewed. This is another bow tie pattern, but what is happening here? That the superior inferior bow tie, as we can see, they are of not the same size. So there is an asymmetry. And these asymmetrical values, this will keep our head that yes, this can be a problem over here. This can be a ectatic cornea. Again, we are seeing a superior inferior asymmetry with superior stiffening of the bow tie. And lastly, this one, this is can be seen in a corneal scar with this very irregular pattern. So these are some of the topographic pattern which we can see in the sagittal or the axial map. From here, where are we moving to? We are moving to the elevation map. For the elevation map, we need to understand something. If we see the earth from a distance, what does it look like? That it is completely flat. The sea, the hills are all in the same plane. But is this true? Of course not. So when we zoom in or we see the topographic terrain pattern, we will see that the hills are there, the mountains are there, and the sea are there. So this is how we differentiate that the earth is not flat. There is difference between the hill and the seaside. So we have a reference that we calculate everything from the sea level. So the sea level is the reference from which we calculate the mountains or any steep part of the earth. Same way, since here, what is the reference? The sea level. We will use the same thing in the cornea, because the cornea, it also has some elevations, anterior or posterior. So what we give a reference plane. From here, any part of the cornea which is above the reference plane has a positive value. And any part which is lower to the reference plane has a negative value. So again, let's have a look of this. So the reference plane of the best fit sphere. So suppose this yellow is our cornea, and this blue is our reference sphere or best fit sphere. So we can see that in some positions, the cornea is going above the best fit sphere. These will have a positive value, and in some position, the cornea is going below the best fit sphere, and this will have a negative value. So we will just keep this in mind when we see the elevation map. We know that the normal cornea, what is its shape? It is prolate in shape. So this yellow, I will just give a diametric example. This yellow portion, suppose this is the cornea, and the blue portion is the best fit sphere. In the prolate shape, the central part is steep and it goes above the best fit sphere, and we can coincide, see, it has a positive value. Then just immediately surrounding the steep part, it goes or dips inside the best fit sphere. See, blue line, the yellow has got inside it. So this part represents this blue part. It has a negative value. Why? It has gone below the best fit sphere. Again, in the far periphery, what we can see that the cornea has gone above or the best fit sphere. So again, in the far periphery, we can see that the cornea has a positive value. I hope that I could make it simple, this part, because these all we will need when we are doing the Pentacam interpretation. So for the Pentacam interpretation, as I was saying, that this is the 4-map refractive, which we see usually. So where do we start the reading? Don't jump immediately into the map. This part of the portion where all the numbers are there, we will start from here. At first, what do we see? We see the QS, that is the quality specification. Is the quality of the scan good? Then the OK sign will come. That means that we can go ahead and take this reading. Then comes just below QS is the Q value. This gives us an idea about the asphericity of the cornea. Value from -1 to 0 seems this will be okay. That is, this is okay for a prolate cornea. But if the QS is more than 0, that means the cornea has lost its prolate shape and it is becoming oblate. That is the periphery and the center, they are becoming same stiffness. And if the Q value is less than -1, that means that the cornea has become hyperprolate. That is, it becomes more steep than normal, which we can see in ectatic corneas. So Q value is done. Now let us go and look at the K1, K2 values. K1 is the curvature of the flat meridian. K2 is curvature of the steep meridian. And just below it is the K mean, that is the average of the K values. Another thing we have to see with the K is a little below, which is the K max. That is the maximum curvature of the cornea. Here we have to see what is the K max, because if it's more than 47, then again we should be suspicious that if this cornea is normal or not. Okay, so next we look at the astigmatism, that is the difference between K1 and K2. We are done with this numerical part. Now we go down, and this is very important. What we are seeing here is the pupillary or the pachymetry readings. So what we see here is the pachy-apex, which is the thickness in the center of the cornea. Then we see just below the pachy-apex is the thinnest location. That is, what is the thinnest location of the cornea. And usually what happens is that the pachy-apex and the thinnest location, these values should coincide or should be near each other. It is good to keep in mind that if there's a vertical displacement of the thinnest location from the pachy-apex of more than 0.5, this is also suspicious. So that we also should keep in mind. And lastly, if we go below the Pachy map, we will see more values from here. One is important, is the anterior chamber depth, which is used in case of some, suppose ICL surgery. This comes to be of value. Now let's switch and come to the elevation maps. So we already know how the elevation maps, positive and negative, comes. It comes with the comparison with the best fit sphere. So the normal values of this is the above one is the anterior elevation map, that is corneal anterior surface map, and the one below is the back elevation map or the posterior float, which is the value of the posterior surface. So anterior elevation map, normal value should be less than 12. If it's between 12 to 15, it is a little suspicious. But if the value is more than 15, we should be very suspicious that this can be a case of ectatic cornea. So for posterior elevation, normal value should be less than 17. A keratoconus suspect, the value comes between 17 to 22. And if we get a value of more than 22, then we should be very suspicious that this might be a case of keratoconus. So now we have interpreted the front part of the pentacam. Now we are going to the back portion. Before we go to the back portion, again, we need to know some things. Number one is the Bellin-Ambrosio enhanced ectasia display. What is this? Dr. Bellin and Dr. Ambrosio, they have done us a big favor and made our life easier, I would say. So what happens is, again, this is a bit tricky, but I'll try to explain it. So we know about the best fit sphere, right? So what happens is, it takes the reading, the raw data of all the corneal reading of the anterior surface and makes a sphere. So in this reading, even if the keratoconus steep cornea reading is also included, right? So this should be the normal best fit sphere curvature. But what is happening, suppose আমি এই জায়গাটি একটু বাংলায় বলছি একটু সবার সুবিধার্থে, যেমন আমার যদি ভ্যালুগুলো থাকছে, সাপোজ কর্নিয়া আমি জানি যে নর্মাল কর্নিয়া কেমন 40, 41, 42, কিন্তু স্টিপ কর্নিয়ার ভ্যালু কেমন হতে পারে ডায়োপটরিক যে 50, 51, 52, তাহলে কি হয় বেস্ট উইথ স্ফিয়ারে কি হচ্ছে এই 40, 41 কেও নেওয়া হচ্ছে, এদিকে 50, 51 কেও নেওয়া হচ্ছে। যখন দুইটা অ্যাভারেজ করি বেস্ট উইথ স্ফিয়ারটা কি হচ্ছে এমনিতেই বেস্ট ফিট স্ফিয়ারটাই স্টিপ হয়ে যাচ্ছে। তখন কি হচ্ছে এই যে আমাদের উপরের জায়গা যেটা আমাদের স্টিপ কর্নিয়া, আমাদের কিন্তু এটা মনে হচ্ছে খুব একটা স্টিপ না, কারণ কি হচ্ছে এটা যে স্পিয়ারের কাছাকাছি। তো সো তখন এরকম যেটা হচ্ছে গিয়ে কিছু আর্লি যে কেরাটোকোনাস আমরা কিন্তু মিস করতে পারি। So I'll just repeat this. So what happens is, since the best fit sphere takes into account normal value as well as the high value and makes an average, so sometimes the early keratoconus can be missed. So what do? We would like to compare or see how the suspect area behaves in comparison to the normal area of the cornea, right? So how do we do this? So what they did is they made a new reference sphere. What they did is, usually what happens that the thinnest center portion, that is the steeper portion, right? So they just took out the thinnest 4 mm zone where the steep cornea is, and then they made the best fit sphere. So আমি জাস্ট বাংলায় আরেকবার বলি যে কি হচ্ছে এখানে, যে স্পিয়ারটা তো আছে কিন্তু স্পিয়ারটা থেকে আমরা যেটা বললাম যে 44, 45 ভ্যালু থেকেও আমরা অ্যাভারেজ করছি 50, 51 ডায়োপটরিক ভ্যালু এটার সাথে যোগ করছি, কিন্তু আমরা যেটা স্টিপ পোর্শন যেটা 50, 51 ওইটা যদি আমি বাদ দিয়ে দিই তাহলে কিন্তু আমার বেস্ট ফিট স্ফিয়ারটা ওই কেরাটোকোনাসের ভ্যালুটাকে বাদ দিয়ে হচ্ছে। সো আমরা যদি দেখি হোয়াট ইজ এগেইন লেটস গো ব্যাক। সো দিস ইজ দ্য ফিট অফ দ্য কর্নিয়া with the new reference sphere. So over here, the ectatic cornea, since we didn't include this in our calculation, this becomes very prominent. So this enhanced best fit sphere, what does it do? It helps us to understand or early diagnosis of early keratoconus. So just let's have a look. This was the original best fit sphere. So the steep portion was very less, and we could have even thought that maybe this is not keratoconus. But once we take the enhanced sphere, the steep portion becomes very prominent, and we know that no, this is not a normal cornea. This is a case of keratoconus. Same way, now let's have a look over here. So the first portion, this is the elevation map as we seen in the front. The second point, the second portion, this is the exclusion map. That is the central 4 mm thinnest part. This is taken out. Then the best fit sphere is made. So the difference between the elevation map and the exclusion map is seen in the last portion, that is the difference map. So over here, any value less than 5 is normal. Values between 5 to 7 is suspicious, so it is seen in yellow, and any value in the anterior more than 7 and in the posterior more than 16 is definitely a steep cornea or a corneal ectasia. So we have to be careful. So even if we didn't get this in the elevation map, because of this exclusion map, this becomes easily understandable. Now we will come to this portion. Over here, what we can see is the corneal thickness spatial profile, CTSP. So what does it do? From the pachyapex, it makes some concentric rings. So there's a ring at 2 mm, another ring at 4 mm, another ring at 6 mm. And we can see that the corneal thickness, how is it going? From 2 mm to 4 mm to 6 mm. And when this is expressed in percentage, this is known as the percentage thickness increase or PTI. So what we are seeing is that as I was saying, that the concentric values, this is shown in a graphical form. The patient's data is seen in red. So this is the patient data. So what are these black dotted lines? This, the center middle dotted lines, this is the represents the normal population average value, the middle one. And 2 standard deviation above this line is the upper dotted line, and 2 standard deviation below the normal is this lower dotted line. So if our patients, that is the red, it stays within the dotted lines up to 6 millimeter, then we can say that this is probably not an ectatic cornea because it's following the normal thinning procedure. Let's have a look at the example. So over here, we can see that no, the cornea is thin. And once we look at this, the red line is completely out of our normal value. So we know that no, this corneal thickness profile is not normal. So we have to be careful with this. And lastly, the end of the pentacam, what do we see? We see this Bell and Embraccio display 2. So over here, we can see some squares. And what are they telling us? So they are telling us the standard deviation of the patient from the mean normative database. And we have these difference values. What are they? The first is the anterior elevation change from the normative data. DB is the posterior elevation. DP is the pachymetric progression. DT is the absolute thinnest location. And DY is the displacement of the thinnest point. So any value less than 1.6 will come as white because it's normal. Any value more than 1.6 to up to 2.6 will come in yellow because it's suspicious. And lastly, any value which is more than 2.6, this is definitely a red alert. So we have to be very careful with those eyes. And what about this last D? This last D is not a parameter. So this is just a analysis, regression analysis using all the parameters that we have seen before against a database of more than 1200 eyes. So this bad display has made our life easier to understand early keratoconus. Now we have talked a lot. Let's go and look at some examples. So where do we start from? As I had said, we see the QS, we see the Q value. Over here, the K1, K2 is 44, looks good. So the one thing I'm seeing that the thinnest location, 491. So this is raising some suspicion. Let's see the maps. The anterior sagittal map looks good. The elevation, anterior and posterior both looks good. But only one problem, the cornea, it's 490. The thickness is less. So this, suppose, has come for LASIK. We should be careful because this is a case of suspicious cornea. So before proceeding, we should rethink. But this is not a case of ectasia. Let's look at case 2. Again, K1 and K2, 46 and 50, raising my suspicion that this is not normal. And we can see, as we have said before, that inferior stiffening is here. Let's go to the elevation map. The anterior elevation map value is 17, more than 12, raising my suspicion. What about the posterior elevation? It's more than 18. This comes to 52. Again, this is not good. Let's compare all this with the pachymetry map. The thinnest location is 446, which coincides with the inferior bowing, which coincides with the elevation map value. So since these are all coinciding, this is not a normal cornea. This is a case of keratoconus. Let's go to case number 3. Again, K1, K2, oh, raises my suspicions. One is 53, one is 60C. And we can see an overall thinning. Can you see that there's an overall, it's all red color. Overall thinning, and the keratometric values are so high. The anterior elevation, more than 12. Posterior elevation, definitely more than 18. It's 64, 63. So there is overall thinning. This is a case of keratoglobus. Let's go to another slide. Over here, we can see K1, K2, 38, 39. What happened? Why is it low? But the anterior map is all green, all good. Elevation, there is very good, less than 12. And posterior elevation is less than 17. So this is all good. But only thing I'm seeing is the red portion in the pachymetry map, because there is thinning over here. So what is this? The K value is less and the center portion is thin, but the elevation maps are normal. So this is a case of post-LASIK patient who has undergone LASIK for myopia. So this way we are going to read the maps. And lastly, let's have a look at where do we use this Pentacam. The first and foremost is for the diagnosis of corneal ectasia, and of course also to monitor the progression of the disease. Second, it is very important to do a Pentacam before any refractive procedure, be it LASIK, be it SMILE, or be it ICL, so that we can understand which patient is suitable for which surgery, and also what will be the outcome of the surgery. And again, if we have to do a retreatment, again, we have to repeat the Pentacam. Even Pentacam is useful in cataract surgery for IL power calculation in premium IL patient, post-refractive surgery patient. That's very important. And lastly, in case of corneal transplant, after transplantation, we can see the healing, how is it going, and also to study the astigmatic effect of the various technique. So with this, I'm at the end of my presentation. If you have any questions, do write it in the comment box, and hopefully I'll answer them all. And hopefully this video presentation will be useful. Thank you so much for your hearing.